Remind me what the conducting zone is. Okay, you said it backwards, but you're good. It's the passageways from the nose all the way through the terminal bronchioles. What is special about this zone? No, we identify it because no gas exchange is occurring. You're absolutely correct. It warms and moistens the air, doesn't it? Very good. And there are changes all along. Most of the anatomy was lab stuff. You're still responsible for the anatomy portion. I can't remind you enough because those should be easy questions. Any of that I choose to ask, like, what kind of epithelium lines the trachea? Yeah, it takes us so long to say that. Pseudostratified ciliated columnar epithelium. What kind of mucosa lines the nasal cavity? Pseudostratified ciliated columnar epithelium, the same. And in the nasal cavity, right, when the nasal cavity's cilia push, they push backwards to the back of the throat. When the trachea's cilia push, they push up. So it's all making sure that the yucky, gunky stuff doesn't leave your body. It's sending it to the back of your throat so you can swallow it. So it can go to the stomach where you have stomach acid that takes care of it. However, we don't like to think about that. But it happens all the time. Here's the end of the passageway, terminal bronchioles. We saw them yesterday. And then after that, we have a respiratory zone. How do we identify the respiratory zone? It's areas where gas exchange takes place. It begins with what tubes? Very easy because the name of the tube is also respiratory. It's called the respiratory bronchioles. And it finishes up at the alveoli. Cool. Then we like to see this. And we want to be reminded that all gas exchange occurs between really alveoli and capillaries, right? That's where gas exchange is made to occur. So this, when I get down here, this is your respiratory zone. But what we want to look at is we want to look at that special membrane called the respiratory membrane. Do you guys happen to remember that? It is formed between the alveolar epithelium, the capillary epithelium, and the fused basement membranes of those two. Look right here. And I'm actually going to blow it up for you, let you see it a little bit better. Here's the alveolar epithelium. Here's the capillary epithelium and a very thin basement membrane that they share. This membrane is so thin. How thin is it? 1/2 to 1 micrometer. That's it. 1/2 to 1 micrometer right here. What's a micrometer? 1,000 times smaller than a millimeter. Okay. 1/2 to 1 micrometer. I have it up on the board for you. Okay. Remember that's 1,000. One micrometer is 1,000 times smaller than a millimeter. Wow. That's small. That's tiny. Or we could say 1,000,000 times smaller than a meter. What happens to the air that's in an alveolus? A lot of the gases move right into the blood. And of course, some of them hang out there and then get breathed out, right? This is a nice little cast of the lungs. And it shows the branches of the respiratory tree, or bronchial tree, passageways in the lungs. Way cool. A bronchopulmonary segment is a region of the lung that is supplied by a tertiary bronchus. A tertiary, that means a third level branch, right? The tertiary bronchi. We know this, but I just want to reiterate it because last night people were getting real confused. What are the pleura? Very thin membranes that surround the lungs. When we talk about thin serous membranes that surround the organ, there are usually how many parts? 2. We usually talk about a visceral and a parietal, correct? Where would the visceral pleura lie? Right on the lung. It is attached to the lung. Betached, detached, C-tached. Okay, no. What is the parietal pleura? That's the one that's outside of the visceral. That's the one that is attached to the body cavity, right? To the wall, the thoracic cavity wall. To the ribs and to the intercostal muscles, so to speak, the internal intercostals. Sound familiar? I bet it does. What do we call the fluid between those two membranes? Pleural fluid. Pleural fluid. It is a serous fluid, you're right. It is a thin, watery fluid, but its name is pleural fluid. What is the function or purpose of pleural fluid? Okay, it's so important. It allows the lungs to slide around in your chest cavity, right? So they don't build up adhesions and stick to things. But this surface tension idea is pretty important too. We've talked about surface tension in an alveolus. Anybody remember what surface tension is? Surface tension is, remember how water is polar? The H's and the O's have little baby charges and they're attracted to each other. So if we had an alveolus that was open and it closed up and the water, the fluid that's on each side touched each other, the alveolus would close up like a little saran wrap bag or something. Okay? And then when we had to breathe next time, in order to open it up, it would take a lot of air pressure to do that, a lot of force to pop them back open. So the lungs make surfactant. It decreases the surface tension. It allows the alveoli to stay open. That's pretty cool. We said that premature babies don't have that. That's why their alveoli tend to collapse. That's why they have difficulty breathing. So that's surface tension in an alveolus. It's due to, well, and it's one reason. Now, surface tension in the pleura is different. We have a visceral pleura and a parietal pleura, and they stay together, right? We don't want them to separate. We want our lungs to basically fill up the cavity and to be out there. So what happens is the surface tension between the two membranes helps to hold the lung against the body cavity, against the body wall. Helps to keep it from collapsing, in other words. Okay, we're going to talk about breathing. What's the fancy way to say breathing? Pulmonary ventilation. You're right, respiration is fine too. But breathing consists of 2 parts. You breathe in and you breathe out. What are we going to call those? Yeah, more commonly in science, in A&P, we call them inspiration and expiration. You inspire and you... How do we breathe? How do we breathe? Good example. There are many demonstrations occurring every second, right? Here's how we breathe. We manipulate the volume of our passageways, our cavities, in order to change the pressure. We manipulate the volume in our respiratory passageways, cavities, in order to change the pressure. See, we know, because we've heard this a bazillion times, that everything in nature likes to move from areas of higher concentration, in this case we're going to say pressure, to low pressure. Yeah. In nature, everything moves from high pressure to low pressure. That's the way it goes. When you air up a tire, where's the high pressure? when you're airing up a tire, right? The high pressure's in the tank. You attach it to the tire, and air moves from high to low. Wow, that's cool. It goes from the tank into your tire and fills it up, high to low. Okay? Yeah, of course. There's many things that go into that. So what we're going to do is we're going to manipulate the volume of a cavity to change the pressure within the cavity. It's really pretty cool, to be honest with you. So let's look at this and see how they're related. What if we have this little box here, like this? Okay? And we say that within this box, there's air. Look, I'm going to show you the air molecules. Don't freak out. There they are. There's some little air molecules. What would happen, let's say this box starts out this big. I'm going to put a little stick here and a little stick here. And what we're going to do with this little box is we're going to push that way and that way. Okay? So we're going to put those molecules into a space that's now that big by pushing them in. Tell me something about these molecules now. They're closer together. Look at them now. Wow, now they're close together. What can you say about the pressure here? Greater pressure. See, when molecules are closer together, they're under a greater pressure. Can you imagine that if you were pushing this with your hands and compressing that air, that it would get harder and harder to push it together, right? It would get harder to squeeze. That air pressure would build up to a point where you couldn't even squeeze it anymore. Nick could, but we couldn't. He could keep squeezing forever, right? Just squeeze them down to nothing. Tell me about, now, the volume of this cavity. This volume of this cavity is pretty significant, correct? Tell me about the volume of this cavity. This cavity has a lower volume. Pardon? Same volume of air, you're right, but we're talking about the size of the cavity. So here's what we say. There is a relationship between pressure and volume. And here's what the relationship is. They are inversely related. They're opposites. Pressure and volume are opposites, or inversely related. However, we even want to be more specific than that. And we want to understand that as humans, the way that we breathe is we change the volume of our cavities, body cavities, in order to alter the pressure. You know, we could say manipulate the pressure if we wanted to. We use volume to regulate the pressure. So here's a real quick, I don't want you to write this down because I'm going to explain it in a little bit. But if we want to breathe in, if we want air to move into our bodies, where does the high air pressure have to be? Outside. If we want to breathe in, we have to get the pressure inside to be lower. How do you get the pressure inside to be lower? You make the cavity bigger, right? Go ahead, take a breath in and tell me what happens to your chest cavity. Go ahead, deep breath. Don't be shy. It expands. So you're telling me that we expanded the cavity and that drops the pressure inside the cavity, and then eventually air can move in. That's exactly how we do it. We manipulate the volume, change the pressure, and air moves in. It's so cool. Well, we want to take it one further. We want to know, and don't worry, I'll go step by step through that process with you in a second. we need to understand that there's pressure around us all the time. I think we do get that, but we don't always feel it. You feel it when you get a sinus infection, when the weather changes. You feel it in your joints if you have arthritis or have had some kind of surgery where you have scar tissue. But we normally don't feel it. But there's pressure all around us in the air. Does anybody know how much pressure in the air around us? At sea level, 760 millimeters of mercury pressure. That's air pressure. That's measured in the exact same units as blood pressure. You happen to remember what a normal, healthy human blood pressure is? 120 over 80. Wow. You're telling me that the air pressure is more than 6 times greater? Yeah, it is. It's more than 6 times greater than your systolic blood pressure. That's crazy. That's a lot of pressure. Why don't we feel it? Pressure in the air pushing in on you all the time at 760. That's significantly greater than the blood pressure in your vessels, right? So why don't we feel that pressure most of the time? Isn't there a song? Okay, anyway. We're born that way. We're born that way. We're born that way. We're used to it. We were born in the air. Any water babies in here? Anybody born in a hot tub? I didn't say conceived. I said born. There's a difference. Okay? Born in a bathtub, born in a river, born in a lake. Okay. We're born in the air. We live our whole life just about in the air. We're used to air pressure pushing on us. We don't feel it. Oh, maybe it's one reason. Maybe it's one reason. Right. Right. Yep. Exactly. So they were talking about going up in airplanes and how you feel the pressure. They pressurize the cabin. You feel it on your ears. Okay? But we don't feel normal air pressure because we're used to it. Yep. You can. Look, this is how hard the air's pushing in. What if we want to breathe out? We have to create more pressure inside of us than that in order to get the air to move out. You have to create a greater pressure in your lungs than there is in the outside air if you want to push it out. It doesn't have to be much greater, but it has to be greater. Correct? That's it. Don't try to digest all this at once. Look here. This is a very ugly simulation of a chest cavity. Okay? Let's draw a new one. Let's make it all cutesy. Or let's not. And let's say we did. So we're going to say that here is your thoracic cavity. Right here. Okay? And look, your diaphragm does something like that. Doesn't it? Dome. And we have a separation, a little gap between the lungs, don't we? What do we call that gap between the lungs, lab people? Mediastinum. Cool. Don't we have these little guys that come in here called ribs? Yeah, we have some of those little things, I think. So there's our little chest cavity. If we want to inspire or have the process of inspiration take place, what are we going to do? I know what you're going to say. You're going to say, breathe in. How do you breathe in? The first thing that you do is you contract your diaphragm. What is the diaphragm? Yes. The diaphragm is a skeletal muscle, in case you forgot that. Skeletal muscle. That means you have some conscious control over it. I dare you, within the next 3 seconds, take a breath in. Some of you didn't like the dare, so you refused. But others of you took a breath in. You consciously controlled your diaphragm. You breathed in. And which way does the diaphragm go when it contracts? It goes down. Like that. Check this out. When the diaphragm goes down and flattens, we have now expanded the cavity. Now the cavity goes from here up to here. That's cool. Another pretty neat thing happens. There's little muscles between these ribs. Some of them are called external intercostals. Those are the outer muscles. You have 2 layers, actually, of muscles. You may remember that from the lab. The external ones, what they do is they actually pull your ribs which way? Take a breath in and tell me. They pull them up. Yes, they do go out a little bit as well. They're being pulled up. And because of the way they attach, they automatically go out when they get pulled up. I'm hoping and thinking that you just noticed that this means that when we breathe in, the first thing that we do is we make our thoracic cavity larger, up and down, that's superior inferior, front to back, A to P, anterior posterior, and side to side, laterally it gets larger. It gets larger in all the directions. That's pretty cool. Therefore, if we increase the volume, what do we do to the pressure? We have lowered the pressure. Notice the first place we do that, we actually do it with the entire chest cavity. So the thoracic cavity to start with. And what that does is that lowers the pressure. Do you know where it lowers the pressure first? It lowers the pressure between the visceral and parietal. What word am I going with? P-L-E-U-R-A. And really, for plural, we would put an E at the end. It lowers the pressure between the 2 pleura. That means that outside of the lungs now, visualize that in your mind. You have ribs, then you have a pleura, you have a teeny, teeny space, and then you have another pleura and lungs. We're saying that between the ribs and the lungs, you have dropped the pressure right there. That little space between the ribs and the lungs. So what do the lungs do when they're sitting in a cavity with lower pressure? They expand to fill that cavity. The lungs expand to fill the cavity. So we're visualizing the lungs just got bigger. You know what we just said? We just said that we increased the volume of the lungs. Correct? Momentarily, the lungs got bigger. As the lungs get bigger, what happens to the pressure contained within the lungs? It must drop. We decrease the pressure within the lungs. We're talking about within the passageways. We're talking about even down within the alveoli. We have now dropped the pressure. Now the pressure inside is lower, correct? Look, we have dropped the pressure within the lungs. So what happens? Air moves from high to low, which we can say into the lungs. And that is how we breathe in. Here's our chest. This time we're going to talk about expiration. Process of breathing out. Well, when we started, we breathed in, we pulled the diaphragm down, we contracted the diaphragm. In order to breathe out, do you know what the first thing you do is? You relax. Specifically, you relax your diaphragm. See, expiration is Normal expiration is mostly a passive process, a relaxing process. When you relax, your diaphragm goes back to its normal size, it lengthens, and when it lengthens, it moves up. What did that do when the diaphragm relaxes? What did that do to the volume of the thoracic cavity? We just lowered the volume of the chest, the thoracic cavity. Okay, we're getting the hang of this. We just decreased the volume. What did we do to the pressure? We increased the pressure. Remember, we're talking about the little spaces here, aren't we? We're talking about the pressure in this dark space that I'm talking about right here. Could we call that pleural cavity? If you called it thoracic cavity, I would know what you mean. I mean the same thing. We would increase the pressure in that cavity. Okay, if we increase the pressure, we're talking about the pressure outside the lungs. Right? The pressure outside the lungs. If there's a greater pressure there. That's interesting. What did that pressure do to the lungs? It squeezes them a little bit, and we get a decrease in the volume of the lungs. The lungs are squeezed. They literally are. So what happens to the pressure as the lung volume decreases? What happens to the pressure in the lungs, in the alveoli? We increase the pressure in the alveoli. Well, now that air that's under higher pressure goes where? Air moves out. Very good. Go ahead. Now, I want you to do this. I want you to take in a deep breath. I know if you're participating. How do I know if you're participating? Because I see your chest go up, right? I see your collarbones raise up. Now, if you breathe out, go back down a little bit, right? Because that's what happens. Now, what if we want to breathe out a little more forcefully? Instead of just, what if you want to go, how do you do that? Is that passive? No, that's forced expiration. That's an active process. If expiration is mostly passive, to force an expiration, or to have forced expiration, or to breathe out very deeply, we must contract muscles. Specifically and most importantly, the abdominal muscles. We kind of know this already. We don't necessarily think about it that much. But if you contract your abs, what happens to your belly? Does it get bigger or smaller? It flattens, right? If you contract your abs, they tighten or flatten. Suck it in. Won't look good. Okay? Go ahead. Give it a try. When you do that, look, when it pulls in, what does it do to your diaphragm? Pushes it up. It actually forces it up. Because, hey guys, whether you're relaxed or not, you have the same stuff in there. Right? It doesn't change. So you contract it. That stuff's got to go somewhere. It gets squeezed tighter. It goes where it can go. Goes up. And it pushes on the diaphragm. So when you contract your abdominal muscles, it helps to elevate your diaphragm even faster, no longer just passively, and it pushes air out. But by the way, that's not all. You also contract these intercostal muscles here that are on the inside, the inner layer. So they're called internal. And what they do is they allow the ribs to come down. So now your chest gets smaller from both the top and the bottom. And that's the difference between forced and regular. What does this do? This creates an even greater pressure change, a greater volume change that creates greater pressure changes that push the air out harder. That's all. It's kind of fascinating to me. Look, you can see that old one. I had all that stuff on there. But notice what I didn't tell you about inspiration. On forced inspiration, if you want to breathe in deeply, you're going to use additional muscles that you didn't use on a normal breath. And here, guys, are the additional muscles. You may remember two of them from AMP1. Unfortunately, we don't cover the scalenes in AMP1. These are little muscles in your neck. They go from your vertebra down to your first two ribs, right through here in your neck. This is where they're located. On the side of your neck, right in here. Okay? Go down to your first two ribs. They pull the ribs up. The sternocleidomastoid, which is right here in your neck. You know, you guys that can't see me, all you have to do is get AMP book and look and find them. They pull your sternum and your collarbone up. SCM, sternocleido, sternum and clavicle, they pull those up. And then your pec minor, which is right here, not sure if you remember, but it's in your shoulder area. It goes from your coracoid process down to a few ribs right here. It contracts in a reverse direction from normally, and it also pulls your ribs up. So all three of those muscles are working to elevate the ribs or elevate the chest cavity. So when you force an inspiration, look how your chest jumps, right? When you force it, you automatically raise up. That's just how it goes. So I like to remind you, because I might ask, what are the secondary muscles of inspiration? That means forced inspiration. But we want to think this way. How good is it for your respiration, your breathing, your ventilation, your inhalation, to have your abs tight all the time? Here's what I want you to do. Wherever you're sitting, contract your abs. And now keep them contracted and take in a deep breath. Okay, blow out, relax. Now here's what I want you to do. Contract your abs, and this time when you contract them, bend forward as far as you can. And now take in as deep a breath as you can without moving back. Deep breath. I want to hear some. But if you want to breathe real deep, you have to go and raise up and down my head, and I'm going to pass out. So that's fascinating. So if you're walking around with your abs tight all the time, you want to impress people, you know, you're on the beach, and you're like, doo-doo-doo-doo-doo, you're liable to get lightheaded and fall over. If you're not feeding your muscles oxygen when you're doing that, when you're contracting your abs, you're not allowing normal breathing to take place realistically. There are some terms that I do want you to know. Atelectasis is a fancy term for a collapsed lung. Now there's another term, a pneumothorax. Do you guys know what a pneumothorax is? That's when you collapse a lung by poking a hole through your chest cavity. That hole goes into the pleural cavity. That lets atmospheric air in there, and it squeezes your lungs. So pneumothorax is a collapsed lung due to a wound. It could be a broken rib. It could be an ice pick. It could be a samurai sword. This is a pretty important slide here. We've already discussed it. I don't need to talk about it. But I want it on integrity so people will see it and go, oh, wow, yeah, that makes sense. We know about this already. There are a couple of gas laws that are important. And we already talked about this. I just didn't name it. It's called Boyle's law. Pressure is inversely related to volume. And when we use that in the body in order to manipulate breathing, which one do we use to control the other? Perfect. We use the volume, the size of the cavity, in order to manipulate the pressure, which allows us to breathe. When babies are in the womb with the fluid, the respiratory gases are coming through the placenta and entering blood vessels that are coming from the placenta and going to the baby. So the fluid within a baby's lungs, the baby's not breathing. Yeah, it comes in through your umbilical cord, and mom's doing the breathing for them. Yeah. So that's why they can live in water. They don't have gills. I don't know if you know that. Yep. And they're full of fluids because they're in a fluid environment. Isn't it cool? And they also, remember, they have the foraminal valve in the heart, the opening that allows blood to shunt because it doesn't need to circulate all through the lungs in the same way that it normally would. Some goes there to feed the lungs to allow them to stay alive. But the rest of the blood is just shunted straight across into the left side of the heart so it can go to the aorta, so it can go to the whole body. It's really neat. Look at these things. What? Physical factors that influence breathing, right? Look, the inspiratory muscles, they use energy to overcome these three things. Airway resistance, the alveolar surface tension, and compliance of the lungs. What is lung compliance? The ability to stretch, right? The ease with which they stretch. Alveolar surface tension would keep them closed. We have to overcome that to open them up, right? That's why surfactant helps a lot. And airway resistance, what's the diameter of the tubes? That's basically what we're talking about, like when we talked about blood vessels. Length of tube, diameter of tube. What is surfactant? What's a chemical? What does it do? Decreases surface tension within what? The alveolus. And what makes it? Generic word would be lungs. More specific word would be alveolus. Even more specific would be which exact cells? The type 2 alveolar cells. These are cells within the alveolus that instead of being the simple squamous little guys that are there for gas exchange, these cells are there to produce surfactant. We already know that in premature babies, they haven't really fully started producing their surfactant, so they have problems breathing because the alveoli can collapse, and they have to use a ton of energy to open them up. Okay? Keep in mind that you're supposed to be going over the homeostatic imbalances in each chapter. Okay? Once we understand normal, then you read those imbalances and you learn a little bit more about the abnormal stuff that can take place. Lung compliance is just like compliance anywhere else. That once again means the ability of a tissue to stretch, how easy it stretches. Lung tissue is very flexible. It's very extensible, distensible. And sure, you would lose compliance if you had scar tissue in the lungs. That just makes sense. Scar tissue wouldn't stretch that much. So if you have long-term inflammatory processes that are producing scar tissue, your lungs are going to lose their ability to expand. Of course, if you don't have enough surfactant, it's going to be harder to open up those alveoli. It's going to take more to open them up. That's going to make it more difficult. And look at this. This is interesting. As you age, usually your thoracic cage becomes a little less flexible and a little less flexible. So it's harder to expand it. Absolute. Oh, I don't know about that, to be honest. That's a great question. Would love it if you would Google it. And then go to a reputable site and make sure they're not lying to you. Homeostatic imbalances. Hey, do you think pain might inhibit you from breathing? Yeah. If it hurts, you're not going to do it, right? Intercostal muscle paralysis, that could happen. Costal cartilage can ossify, can become bone-like. Holy moly, you don't want that. That's going to make your thorax become rigid. What about scoliosis that changes the size and the shape of the cavity? What about a sternum that's caved in, right? What about ribs that aren't formed properly? There can be all kinds of deformities of the thorax as well. Lots of things.